All right, we are recording. I'm going to go ahead and kick this off. Thank you all for joining us today. We are going to be talking about patient and family partnership in diagnostic excellence. And we have two speakers with us today. For some reason, my slides are not progressing.
Oh, is it because I didn't say got it?
No, it's a
No.
technical, hold on just a quick second. Technology. So our two speakers today are Dr. Sigal Bell. Sigal is the Associate Professor of Medicine at the Harvard Medical School and Director of Patient Safety and Discovery of Open Notes at Beth Deaconess Medical Center. Eric Thomas, Dr. Eric Thomas, is the Director at UT Houston Memorial Hermann Center for the Healthcare Quality and Safety and Associate Dean of Healthcare Quality. So I just sort of want to frame our presentation today. A journal article came out earlier this year looking at the burden of serious harms from misdiagnosis in the US. And we've focused so often on the acute care setting, and we've heard the numbers from anywhere 44 to 98,000, then 250,000, up to 440,000 lives are lost a year due to medical errors. But we've not really looked at the diagnostic side of it as much. And this study came out and said that roughly 795,000 lives are lost or have suffered either permanent disability or die because of misdiagnosis. So what we're here to talk about today, and I'm sure Eric and Sigal may get into this study more, but I wanted to pull up one study to show you really who we have on board talking to us today and the work that they are already doing, engaging patients and families in this whole diagnostic safety process. So with that, I'm going to stop sharing and I will turn it over to you, Sigal.
Fantastic. Thanks so much, Carol. And I'm just going to bring up my slides. Perfect. Well, Eric and I are so thrilled to be here today and to join all of you to talk about something that's near and dear to all of our hearts, engaging patients and families in diagnostic safety. And I've had the pleasure of working with Eric for over a decade now. Much of our work really focused on engaging patients and families. And we've also had the great fortune of working with many of the patient and family advocates that are here today and now part of PFPS US. And so much of the work that we'll show you actually came out of collaboration in one way or another from many of the folks on the screen and on the call today. Here are our disclosures. I'll just mention that Eric and I are ARC funded and have some other grants, including from CITM for work that you'll see today. And then other than that, the funding we receive is unrelated to this work. Today, we're going to take you on a little voyage. When we were preparing for this talk, Eric said, well, wouldn't it be great if we could kind of summarize the journey from Open Notes to RDX? I'd really like to see that integration. And RDX is the little spoiler alert or kind of, here's what we're coming to that Carol shared with you just moments ago. And that's a 10-year voyage. So my task today is to kind of condense 10 years into about 30 minutes. So we're going to move quickly, fasten your seatbelts. And after we go through that, Eric will talk with you about our current grant, which also partners with Patients for Patient Safety US, looking at coupling teaming science with patient engagement in diagnosis. And while we're talking about these two kind of big picture items in our agenda today, it would be great to think in the back of your mind about how some of this data that we're sharing and the experiences and lessons that we've learned inform the development of patient-reported measures, which I know is a priority for so many of us on the screen, and certainly for PFPS US with its new pivot project. And I hope that this will show all of us the many synergies in the work that we're doing and the places that we may go with this information. So let me start with just sort of a foundational thing to put us all on the same page, so to speak, in terms of what Open Notes is: the transparent practice of sharing electronic medical notes with patients, usually through the patient portal, but this can be done in any fashion. And most of us today, I think of Open Notes in the context of the Cures Act. But I just want to point out that in the US, the Cures Act was implemented in April 2021 and really speaks to both transparency and interoperability. So Open Notes is actually just one part of the Cures Act, and the bulk of data behind Open Notes really refers to research that took place in the ambulatory setting, whereas the Cures Act is talking about sharing medical notes across all kinds of clinical settings. So I just want to be clear about where the data is coming from that we're talking about today. And I also want to point out that while most of us have learned about Open Notes through the context of the Cures Act, this is a mission and a voyage that started long ago, more than a decade ago, before COVID, if you can even imagine that time. And this is started in Boston, at least in 2010, with a proof of concept study where 100 providers invited 20,000 of their patients to read their medical notes through the patient portal. And the big question with this proof of concept study was what would happen in terms of patient engagement and in terms of provider burden. And what we learned at the end of that 1 year experiment is that 99%, sort of a stunning statistic when you think of thousands of patients, wanted Open Notes to continue and reported many, many benefits with regard to patient engagement and education. And none of the doctors, quote unquote, shut off the Open Notes in terms of access for patients to read their notes. And so this result ultimately led to the growth of Open Notes as both a concept and a movement, from 20,000 patients to 1 million patients to 50 million patients over that ensuing decade, and ultimately to the Cures Act in 2021. When we go back to 2010 and the very early days of Open Notes, there was a lot of anxiety about what would happen if we share notes with patients. And it's almost surprising when you think about it, because we hear comments from patients like, why am I the last one in line to get access to my health data? But here were some of the things that we were hearing early on. And what I found was that these were very early windows into the many safety opportunities that were waiting for us by being able to invite patients to share their medical information. So first we heard about follow-up tests. This is a patient who said, weeks after my visit, I thought, wasn't I supposed to look into something? I went online immediately, good thing. It was a precancerous skin lesion my doctor wanted removed, and I did. Another commented about medical error, and this was a patient who realized that she read notes about the wrong issues and commented to her provider about that, who acknowledged she had confused her with another patient. Also, on an occasion, she made a statement about increasing the dose on a medication that I never took. We hear a lot about understanding the rationale. When I realized what it was doing for my breathing, now I know how important that medication is. And we also hear about care partners for whom Open Notes has been a tremendous benefit. So those who care for others, perhaps even those of you on the screen today, have loved ones that you care for, maybe even across state lines. And it's very difficult to keep up to date with what's happening with medical care and really be able to offer the best care and support without access to that information. And this is a patient who says it's really much easier to show my family, who are also my caregivers, the information than to try to explain it myself. I find the notes are more accurate than my recollections. And again, we heard patients talking about better remembering the visit. And I remember in distinction, a particular PFAC member who said to me, was describing an interaction of going to healthcare visits with his sister, for whom he served as the care partner, and said, you know, Dr. Bell, it's like you walk out of the visit and all of a sudden it's like big amnesia. You know, did he say this or did he say that? And I just love the term because I think it's something we can all relate to, even in our own healthcare encounters. So over the years, we led those studies following the leads that were coming from these patient comments. And through numerous years of research and multiple publications, we came to recognize that there were three major ways that open notes can serve as a diagnostic safety and quality strategy. So first is this very notion of just remembering next steps. And in relation to diagnosis in particular, being able to complete diagnostic tests and referrals, which we know are a hot topic and a key issue in keeping the diagnostic process on track. But it's not just remembering. What we came to learn is that patients were gleaning benefits even from things that were between the lines. It wasn't just what was in the note, but sort of the notion of understanding that their doctors and clinicians had taken the time to think about them and to really process what was going on in their care. And so there was a strengthened relationship that we were seeing in terms of trust, teamwork, and alignment, where patients would read their notes and recognize, like, oh, he really knows me, she really understands. There was a way of relationship building by sharing this information and making a commitment to transparency and therefore greater trust. And the third major way that we discovered is that patients can identify breakdowns and documentation errors. They can also identify breakdowns that are not in the chart and therefore help us to fill a gap where we know that the medical record is not always accurate or complete. And in our research, we found that the majority of these were clinically relevant. And so these data help to inform numerous publications that have come out in promoting safety, including the most recent Safety Together National Action Plan from IHI and ARC. So let me share with you just some examples, like what kinds of things do patients find in their records. So here are a few. Medical history, for example, the doctor reported that I did not claim to have pain in my hand, but I'm a pianist and I went specifically because the pain was in my hand. Another example, the notes regarding sinus pain were not accurate as to the area that was being affected. It mattered to me because I had recently had dental work in the actual area. So this is a patient who knows this important nugget of information that the provider has missed and can help with the diagnostic process. Tests or the wrong patient, plan to change medication based on the lab results of another patient. Diagnosis, saying I'm BRCA when I'm not BRCA positive. The care plan, an incorrect dosage on a note that was being used by a physician for an infusion. The dosage was incorrect by 10-fold. And even simple things, or what we often consider to be simple things, but can have vast impact, copy-paste behaviors, right? It might say she complained today of headaches when I've not complained of a headache in a year. This can be upsetting because it makes me feel like I'm not being heard, or like medical decisions might be based on inaccurate information. And what we found when we analyzed these systematically is that the majority of patient-reported errors from reading notes may affect the diagnostic process. And so we call these patient-reported diagnostic breakdowns, or PRDBs, and you'll hear more about those as I go on in the presentation. We also found that patients can find PRDBs in every step of the diagnostic process. However, as I'm sure is familiar to many of you, patients were using different words. They weren't commenting on like failures of information integration. They weren't commenting on processes in the diagnostic process. They were talking about things like not feeling heard. They were talking about non-responsiveness, multiple attempts to fix errors that they were perceiving, but still finding it wrong and eventually just giving up. They were talking about things that were missing. Again, the medical record not necessarily being the gold standard. They were talking about lack of contingency planning. I didn't know who to call or when, confusing or conflicting information, misalignments where, actually my perception is that this didn't happen at all. So the patient and the provider being on different pages. And they commented about disrespect, the sense of not being taken seriously, that their concerns were dismissed. So we thought to ourselves, where does this fit? Where are these concerns being heard and categorized and counted and measured? And we realized that it's this classic adage that every system is perfectly designed to get the results that it gets, that you can only find what you're actually looking for. So we thought, well, let's think about a way to create names and labels for these things so that we can systematically look for them. And we thought that this would be an important way to fill the gap in safety metrics, because clinician-centered metrics and taxonomy do not always capture the words and the concepts that patients and families are using and their lived experience of diagnostic breakdowns. And so we knew we were missing these important events. And we also know that as a basic safety tenet, multiple perspectives are really needed to fully characterize the problem. So there was this whole piece of diagnostic excellence or lack thereof that was being missed. So we put together a multi-stakeholder advisory group, and we analyzed 2 large data sets with over 30,000 patients and over 2,000 patient-reported ambulatory events to ultimately create a patient-centered framework for diagnostic process breakdowns. And this is part of the framework. The framework is broken down into description of the breakdown itself, the contributing factors, and then the impacts on patients and families. Here we're looking at just the breakdowns, and it's a complex forbidden small font slide, but I just want to give you the aerial view. And what you can see from here is that the overall shape and the maybe some of the cornerstones look similar to the NAM model, but what you see in blue are newer areas that we are bringing to this diagnostic model, diagnostic processual model. And one key element is this issue of access. How do I get in? How do you engage me as a patient so I can enter the diagnostic process? And this has to do with literal access to care, but it also has to do with a more conceptual or philosophical willingness to share health information and to invite patients and families in, to meet them where they are, and to help educate them so that they understand the warning signs of when things aren't going quite right and move along with their providers through the diagnostic process. You also see in blue and intentionally designed to move across all the elements in the NAM model, this notion of communication and respect. And this is a piece of what patients are telling us in every step of the diagnostic process. You can see in the smaller categories here on the right that we're talking about issues of not feeling heard, about misalignments between physicians and patients, about their particular symptoms, the importance of those symptoms, inadequate communication about uncertainty, lack of transparency, and discomfort speaking up about concerns. Just this alone, I think, opens the door to so many issues in diagnostic breakdowns that weren't necessarily being previously captured. And even in those areas that are represented in more classic models of the diagnostic process, the subcategorizations are unique from the patient's perspective and bring to light additional ways of recognizing breakdowns that clinicians may not be aware of. So when we applied that patient-centered framework, the breakdowns, to our data on patients who reported errors in their notes, what we found is among 22,000 some odd patients at 3 sites, 6.4% reported at least one PRDB. And when you look at patients with chronic illness, that number went up to about 10% who found at least one PRDB. And when we categorized them, the majority had to do with medical history, not surprisingly, since they are looking at their notes. But also you can see this important signal around communication and respect. And the other most common categories were around tests and referrals and explanation and plan, where explanation essentially was the lay approach to the diagnosis. So around this time, something interesting was happening, which is that there were a couple of investigators in the UK at the London School of Economics, Gillespie and Reeder, and they had coined a term in healthcare called blind spots. And they used a data set that was derived from patient complaints in the UK. And what they found is that the blind spots that they coded in these patient complaint letters actually correlated with safety risks at the organizational level. And these blind spots were safety issues that patients or families know about, but providers or organizations may not necessarily observe. And so we got very curious about this notion because we thought, well, isn't this fascinating? With open notes, the whole idea is that patients can read their notes and find things between visits where providers may not necessarily be with them at that time. And we thought that between visit category might be the most important place where blind spots occurred. So we turned to our data and asked the question, of these PRDBs, can we identify blind spots? And over 50% of those PRDBs were potential blind spots, and they were categorized into the similar categories that Gillespie and Reeder had derived in their own analysis, with one addition around diagnostic misalignment. So again, where providers had recorded the wrong symptoms and wouldn't have known were it not for patients reading their notes with breakdowns and explanation or next steps. Maybe what the provider wrote was not what was spoken at the visit, or was not understood as the way that it was written. And then, like Gillespie and Reeder, there were omissions. There were indeed problems between visits, including access and tests and referrals. And there were what Gillespie and Reeder call multiple or low-grade problems. These are small breakdowns that in and of themselves may not lead to a major problem, but they begin to snowball and in their collectivity lead to a breakdown. Interestingly, in our data, despite our initial hypothesis, the between visits was not the largest category. In fact, it was the misalignments that was most commonly viewed. So it helped us to realize this notion of distributed cognition, that in fact, patients hold key parts of the puzzle that are not captured in traditional safety data or EHR triggers. And it is so important to bring together the cognition, the knowledge that patients and families have with that clinicians bring to the table. Many of the patients in the study actually acted on those things that they found, resulting in what we would call good catches. And so this work really led us, it was published in Milbank, which many of you know is a policy journal. So we really thought hard about the policy implications of this work. And there are 5. The first is that patient involvement in diagnostic safety is essential. So it's no longer a question of if, but how. The second is about patient good catches. So, we don't really talk about that in medicine. Surprisingly, there are many programs that talk about clinician good catches, but where are the patient good catches, right? These should be invited, supported, celebrated, part of our culture. The third is that Open Notes provides a new scalable platform for patient engagement. And this is because of the critical importance of providing patients with their information so that they can then identify the gaps. Many of the patients did not even know that these blind spots existed had it not been for reading their notes and then realizing that something was missing or something was incorrectly captured. The fourth is the desperate need for routine systems for patient feedback to be able to harness this unique patient safety knowledge and bring it back into the system. And finally, policy and resources to diversify patient participation in order to avoid safety disparities. So now we've set the stage and we've arrived at the main event of RDX. How do we now use this information that patients and families have to help them engage as diagnostic partners and bring this information back to clinicians. So this is our challenge. And we really wanted to think about the following considerations. So we needed a process that would proactively and systematically engage patients to collect information. We wanted to use existing scalable technologies and workflows. And we really needed to create an opportunity to be able to close the loop on this information that was being provided. So we designed the RDX tool together with patients and families over about a 9-month process, and really building off of what we learned from the patient-centered framework. So there's 3 main categories. The first is about priorities. What is the most important thing that you want to talk about at your visit? And the goal of this item was to address that issue of misalignments. We really wanted to encourage shared agenda setting between physicians and patients on what is most important and call that out front and center. The second is about recent history. So over the last 6 months, have you had, and there's sort of check boxes on a number of conditions that we know may increase risk on diagnostic process breakdowns. And so this was a way to quickly flag for clinicians diagnostic processes that may be at greater risk. We also invited an open narrative on what's been going on with recent symptoms. And here we are looking at those common breakdowns in history where the symptoms just were not captured correctly. So now we can get it in the patient's own voice. We can bring that information directly into the medical record. And the third section was about getting it right. So we looked at the other common breakdowns in the PCF. Do you feel that your main concerns have been heard? Have you had problems or delays with tests or referrals? And then kind of a catch basket for anything else that patients wanted to tell us regarding potential breakdowns in the diagnostic process. And we ended too with an opportunity and appreciative inquiry, is there anything that's going particularly well in your care? Again, enabling some of that feedback back to providers to capture and reinforce the things that were positive and were going well so that clinicians knew about that too, and which behaviors to continue to emulate. Here's how we designed it. So again, this is really capitulating on the idea that we wanted to make sure that feedback was coming back to clinicians. So we invited patients to complete the RDX tool before a visit. The data flowed into the EHR where clinicians could reach it, access it, and even before the visit, and facilitate agenda setting, as we mentioned, and improve potentially the visit efficiency by having some of that information up front. They would conduct the visit with the patient, write the note, where they could pull directly from RDX if they wanted to, in terms of in their own note writing, and then share the note with the patient and family member. Now you can see how for patients with chronic illness, this very much becomes a cycle of care where what happens before one visit is what happens before the next visit, right? Sorry, after one visit and before the next visit, so that there is a real cycle of engagement and a connection between RDX and open notes. So here are the study setup was pretty simple. 4 clinics at 2 academic hospitals, real life integration in terms of the technologies that were being used at each system. And we really wanted to know 3 things. Would patients use it? What would they say? Would it be actionable information? What are the safety opportunities? And what does this mean in terms of equity? So what happened? Well, patients did use it. So after a year, we had about 7,500 reports from these 2 sites. 11% of these patients with chronic conditions did report potential diagnostic breakdowns. So recall, this looks quite similar to the 10% that we found in PRDBs and cross-sectional data. And 98% of the information that was provided in these reports were actionable. Well, what did they say? We broke the contributions down into 10 categories. And overall, patients provided an average of 3 contribution categories in their reports. When we compared reports where there were diagnostic process concern, we were more likely to find these categories in blue: access barriers, recent visits for the same problems, test or referrals, care coordination, communication issues, or other problem and delay. This is not surprising, right? We know that these things are associated with diagnostic process breakdowns, but interesting that patients can tell us about them. In chart review, we found that 63% of these things that patients were reporting were probable, what we call diagnostic safety opportunities. 38% were possible, meaning there just wasn't enough information for us to know exactly what patients were describing, again, likely because not everything is in the chart. So here's some examples of things they said. So I continue to have tightness in my chest. I had a cardiac cath at another medical facility recently. So imagine if you are the provider and now you have this information coming to you, proactively, so you know that you need to have your eye on those results from another center, information that may not otherwise be readily accessible to providers. Not feeling heard, very common thread. I think that no one has understood our situation. This particular patient took it upon herself. I'm afraid of not being clear enough. Coordination of care. Each person treats their own issue, but we're often left as parents trying to figure out the puzzle. History. And I just want to pause here for a second because I think this is so compelling. This is a mother who's talking about their child, scared and startled, holding her breath at least 15 times a night. She's yet to sleep through. I'm very concerned for her. I myself do not sleep listening to her struggle to breathe all night. Now, when I was in medical school, we were taught how to describe symptoms. Where is the pain? Does it radiate? What is the severity? They're very clear descriptors. But what is absent from those descriptors is like, what is the impact of those symptoms on the patient and family lives? And, just this message alone, really changes the way a clinician might think about a particular encounter. And an opportunity to accelerate diagnosis. So, sometimes patients provided information that could accelerate testing even before the visit so that the diagnosis is already made and can be treated at the time of the visit or even before. A couple of words about equity. We know that individuals at risk for healthcare disparities may also be at greater risk for diagnostic error for multiple reasons. And we also know that those errors may be less likely to be reported. So we wanted to take a look at how, in this case, patients with limited English proficiency, Spanish preferring patients, were experiencing the diagnostic process and interacting with RDX. And as always, it's the patient stories that are the most compelling. These are mothers of children who, we ask how, what does the diagnostic process mean to you? How would you describe it? And this mother said, difficile lento, which again is this term that just sticks with me, difficult and slow. Here's a mom who says, the doctor in the ER said, your child is epileptic. And I didn't know. No one had told me anything. So the diagnosis was never communicated. Multiple specialists. This mom saw maybe 10 specialists with her son and said, for the majority of them, they listen to me, but they don't understand me. And then here another mom talking about the barriers to sharing information. So just trying to get some records from the hospital to share with the school health team. Do you know how long it takes to get someone at the hospital to answer the phone? Just the simple logistics of trying to coordinate care. When patients who prefer a language other than English answered the survey, we looked at, how often they registered responses. And what's interesting here is that in this category of RDX that had to do with breakdowns was the most commonly responded section of RDX for both English speaking and for patients who preferred another language. As you can see, some of the free text items were less commonly completed, and that, of course, was more difficult with language barrier as well. In the end, the diagnostic concerns by language preference was striking, where there was 2 times greater reporting of any PRDB by patients with limited English proficiency, and 5 times greater likelihood of reporting that their main concerns were not heard. So sort of sobering statistics. So these are some high-level take-homes. I'm not going to repeat them in the interest of time, but I do want to just share with you one last thought, which is a little bit of a personal reflection. So, people say, There's this adage, right? Like start with the end. If you're tackling a problem and you're not quite sure, like think about, what you want the end to look like. And, when I think about this particular patient, it's almost like ending with the beginning. This is a woman who made a comment to me when we were first starting the project, a patient who was part of the RDX team. And I'm gonna share with you what she said. I'm going to borrow Carol's language from yesterday, which is, you're not supposed to read all the things on the slide, but I'm going to do it anyway because we think it's important. I heard you say that yesterday, Carol. And I want you to just think about, as we're reading this together, like, how are we actually assessing this patient's diagnostic process experience, right? What are the measures that let us know whether this is going well for this patient and what's missing, and how do we think about filling those gaps? So here's the mom. As a mother of 3 children, I interact regularly with doctors, nurses, and physician assistants and feel responsible for the health and well-being of my family in ways that are visible and invisible to providers. We'll come back to that. How do we make it not invisible, right? For our family, that process of reaching a diagnosis has on occasions been a complicated, confusing, and emotionally exhausting journey. But this experience is rarely discussed in clinic visits, nor is it documented in our notes, even though it becomes a core piece of who we are, how we move through the world, and how we interact with healthcare professionals. It also affects how we live with our diagnoses, our trust in our providers, and our willingness to engage in treatment. I have often wondered how and when to share these parts of our story. So with that, let me pause and transition over to Eric. I think this is a nice way for us to consider not only where the breakdowns are in the diagnostic process, but also how do we create safety in the diagnostic process. And for this particular patient, and many, as we're coming to learn, creating safety has a lot to do with also creating emotional safety. And how are we going to create our patient-reported measures to reflect that, to understand what it is we need to do to help patients feel safe? So I'm going to forward through just a couple of these last slides to bring up Eric's slides, and I hope I'll have a chance to hear some of your questions in a few minutes. Over to you, Eric.
Okay, thank you, Sigal. And I'm going to be brief, just about another 10 minutes or so, and we'll finish up and have some time for some discussion. So I'm going to talk about our current and future work, and I want to frame it in the context of what people lately have been calling Safety 1 and Safety 2. And this is a very brief kind of description of these two ideas and not at all comprehensive. But Safety 1 is what we're referring to as our approach to most of our approach to healthcare safety since To Err is Human about 20 years ago. And so in general, the thought in Safety 1 is that we're trying to eliminate harm, we're identifying errors, we're reducing them, maybe even eliminating them. And safety under the Safety 1 rubric is defined as the absence of error. And now people that are talking about Safety 2 say that, well, there's a lot of inherent risk in everything we do, and let's focus on resilience and how we create safety. So instead of thinking about safety as the absence of error, let's think about it as the presence of safety. And so you got the next slide, please. This is the lens through which we're looking at our work now as Safety 2. So in Safety 1, we're thinking about our care processes as these predictable sequences of steps, and they can be executed, safely if we have support from things like checklists and bundles and algorithms and decision aids and all the kind of tools that we're trying to use to make sure that things are done reliably. And many of our processes are like these Safety 1 processes. There, you think about the success that we've had in many organizations of eliminating catheter-associated bloodstream infections. Well, that's because you can identify a series of steps that you do. You put them on a checklist or a bundle, when you insert the catheter and when you take care of it. And if you adhere to that process reliably, you can eliminate that safety event. But as what safety two says, helps us to think about the fact that there are a lot of processes in healthcare you can't boil them down to just doing it by a checklist, right? A lot of things are extremely dynamic and complex, unpredictable. We have shifting teams and tasks and risks, and it can't be easily standardized. And we really felt like this idea of safety two is what applies to the outpatient diagnostic process. So here's just another schematic. Under safety one, we talk about things that might be complicated, but you can still map them out. So again, an example might be the administration process for medications in a hospital. That's complicated. There's a lot of steps, but you can map it out. It's a sequential thing, and you can do things to try to force it to happen reliably. But outpatient diagnosis is often like what we see on the right. It's complex, it's unpredictable, and we don't really know for sure how it's going to unfold. And even more specifically, we're talking about, for our research now, situations where patients come in to see a primary care physician with a new symptom, and they don't get a diagnosis at that first visit. And so then they enter into this outpatient diagnostic process, this journey that the patient that Sigal quoted was referring to. And so how do we create safety during that journey if we can't predict exactly what the steps are and we can't make a checklist? What are we going to do? Next slide. So we think there's an enormous potential for thinking more about teamwork and specifically teaming with patient engagement. And of course, the idea of teamwork in healthcare and studying it and improving it is not new. But there's a little different flavor here when we're talking about teaming. So next slide. This is just the a depiction of our grant from the Agency for Healthcare Research and Quality. They has created a diagnostic center of excellence that we're calling Safety Together. Again, coupling team science and patient engagement. Next slide. And just quickly, the specific aims, just so you know, on the left side of these slides. First of all, we are doing what's called diagnostic mapping. So we're doing really in-depth interviews with patients and clinicians and care partners and interpreters to understand this journey that these people are on, that are going through together. Next slide. We then want to, of course, develop tools to help these teams, these individuals work as teams, and to navigate risk and to create safety and ultimately end up with a safe diagnostic process. And then next slide is just also a goal of these diagnostic centers of excellence is to build capacity for research and practice and diagnosis. So that means engaging learners and partnering with organizations like Patients for Patient Safety US, Open Notes, and Language Line, which is a national interpreter company. Next, please. Just quickly, the project is comprised of individuals from UT Health Houston, where I am, Sigal's organization at Beth Israel Deaconess Medical Center. Our team scientists are Eduardo Salas at Rice and Scott Tannenbaum at the Group for Organizational Effectiveness. Next. So you all know that there's a lot of research on teams and how teams can work better together and be effective. Going back about 30 years. And when you add it all up, we know that good teamwork is a powerful deterrent of error. It's a catalyst for safety and for overall effectiveness of care and of the teams themselves. Next. And we're going to talk a little bit about teaming. So teaming is something that happens when individuals, next slide, yeah, have to coordinate and communicate with each other. And then next. And when it happens when people have to come together to address a problem, make decisions, support each other, give advice, update each other, they rely on each other. And hopefully this is sounding kind of like the diagnostic process, right? This is what has to happen. This is happening between healthcare providers, patients, family members. It's not always the same people doing the same sequence of tasks. So again, we get to this notion of how complex this can be and how this safety two lens can be helpful. And the boundaries of the team are fuzzy. So next slide will give some examples. Continuous teamwork, like we've traditionally thought about it in healthcare, might be, the team in my office. So as a primary care physician, when I go to see patients, I know that I have this stable team. I'm very fortunate. I know that Shannon is going to be there. She's the LVN. I know Tony, my medical assistant. I know the residents. I've got several nurses on the phones that are helping take care of our patient and manage portal messages. It's a stable team that's wonderful. But once I see a patient and I don't know what's wrong with them, and I engage in an outpatient diagnostic process, I start to involve people that I may not know very well, right? I may or may not know the patient very well. I may or may not know their care partners and their extended family that are involved in their care. I may not know all of the specialists that are going to be involved, the radiologists, the laboratory technician, on and on and on and on, right? So we start entering into this process of teaming, where things are shifting a lot. We have different people, we have needs for different expertise. There are emergent challenges that happen over time when we're not, together face to face. This is teaming more than just traditional teamwork. Next. So the challenges that we have, this is very hard, right? Because we've got shifting team members over time. We're not together in the same place. There are power differentials. This is perceived, but also real differentials in power. People often feel unheard or lack agency, especially, of course, patients. There are often language barriers. We can't just script out this process. There's a lack of role clarity. There's no team identity necessarily, because we've just come together, to form this team to help take care of the patient over time. And oftentimes we're dealing with incorrect or missing information. Next. Now, we know from, again, decades of research and nicely summarized by Eduardo Salas and Scott Tannenbaum, that there are some key drivers of teamwork and teaming. And we've adapted some of these to the diagnostic process. So Eduardo and Scott have the 7 C's of teamwork. And Sigal, you can go ahead and go through this and fill out this slide. I'm not going to read through it all. But there, the things like capability. You've got to have people that have the right skills. They have to be able to cooperate with each other. There needs to be psychological safety. They need to coordinate. They need to communicate. They need to have a shared cognition or shared understanding of what's going on. The other term that's often used is a shared mental model. That's really important. Eduardo and Scott use the term coaching instead of leaders, so they can have 7 C's and not 6 C's and an L. But there needs to be some leadership on this team, right? And they have to have the right conditions in the organization to allow them to work together effectively. Next. And this is actually my last slide. I want to highlight some of the measurement that we're going to be doing in this project. So in addition to the interviews that I mentioned, we are going to be surveying clinicians and patients about several things. So one is this concept of a shared mental model. So there's a little bit of work on shared mental models in healthcare teams, but not much. And we're going to be asking them in the survey about shared understanding regarding the tasks that need to be done, the use of equipment and technology, the roles and responsibility, who has what skills, and what's the timing and the urgency of this process, right? So to do this correctly, the members of the team need to have the same shared mental model about all of these things. Diagnosis in the outpatient setting is also about care transitions. And there is a care transition measure that's been developed, and we've adapted it for diagnosis that we'll be also using as a survey. And we've adapted Epstein and Street's patient-centered communication model for diagnosis. So hopefully we'll have some nice short surveys that patients and clinicians can fill out to help us inform how things are going with diagnosis. And then the next, just to briefly mention again what Sigal talked about, the patient-centered framework also identifies some categories for patient-reported measures, especially the patient-perceived breakdowns that Sigal mentioned. She didn't talk that much about patient-identified contributing factors and the impacts, of course, on patients of diagnostic breakdowns, but those are also areas that are certainly amenable to patient-reported measures of diagnosis. Next. And I think that is it. So thank you all for this opportunity to share our work with you. A lot of you have been involved in this, as Sigal said, and literally, you know, tens of thousands of patients through the surveys and the other, you know, work that's been done over the years. So it's really nice to have this chance to summarize things and share it. And lots of other people have been involved in this work as well. So thank you.
Wonderful. Thank you, Sigal. Thank you, Eric. So what we'd like to do now is open it up to questions that anyone may have. We can do this a couple ways. You can raise your hand. You can just unmute. You can type something in the chat if you would like to do it that way. Okay, Suze, you're up.
Hi, thanks. Thank you so much. This has been great to watch and hear. And I hate to even bring this topic up, but when I think about promoting wider uptake and use of these types of practices, I'm curious about how you navigated or whether you encountered concern about legal ramifications by exposing, you know, breakdowns or misses or good catches. And did this all happen in PSOs, or how was that managed, and how can we think about that going forward? I just see it as sort of the immediate first barrier that hospitals are going to kind of be nervous about exposing, you know, even slight misses. So curious about that.
I'll speak up first about our initial work, and I'd be interesting about some of our most recent work, but I think it'd be interesting to hear what Sigal has to say about maybe open notes over time and kind of initially how that was dealt with. But frankly, I mean, we have not had much pushback at all. Now, that's probably because we're dealing with, you know, just selected organizations, obviously, that are willing to do this kind of work and are open and transparent. I think it is going to be a problem, certainly, for some organizations to be comfortable with patients, you know, reporting things and just being more open about sharing information and being transparent. You know, fortunately, things are getting better, but not as fast as they should. But this work can be done without, you know, concerns about legal ramifications, and it should be. I don't know, Sigal.
Yeah, thanks. It's a great question, Suze, and great to see you. So, you know, I think we worried about that a lot too. And actually, what was interesting is that the very first precursor study to this work, which I didn't have a chance to show you today, but was actually funded by CRICO, our malpractice insurer. And so, you know, which really showed a vote of confidence for the work that we were doing in engaging patients and families, because inviting them to tell us about concerns makes it less likely that we will ultimately miss things and end up with downstream errors. So, you know, I think that kind of puts the framework or the right perspective around this work. The second thing that I'll mention is that doing it in this way creates a more organized pathway, because it gives a system or a framework for which to hear and respond to patient concerns, as opposed to kind of the one-off comments that would otherwise potentially come through to individual providers without the scaffolding or system around to handle those. It also, I would mention, makes it impossible, really, or much harder to study what it is that patients are, you know, writing in when it's in the one-off manner. So it's much less fruitful from a patient safety perspective. And then the last thing I would say is about loop closure. So that is the very reason why we designed this to happen up front before the visit, so that the information flows to a live person who is sitting in front of a patient. And we thought that was really critical, because we've tried it the other way, where it's after the visit, and we did have loss to follow-up where patients just didn't answer follow-up phone calls, or, you know, were harder to reach. And so that opens up much more liability. So I think those three factors really help to mitigate some of the concerns. I hope that's helpful.
Sue.
Yeah, thank you. I mean, I'm really familiar with these projects, but I'm just so impressed at your presentation. It was so clear and terrific. And I'm excited that other people are going to be able to see this. And something, Sigal and Eric, as you were talking, and we've already connected about this, but we last week had or whenever it was, we had a webinar on Project Pivot. And there's a lot of interest right now in patient-reported measures. We're not learning enough from the patient community. And as you know, the President's Council of Advisors on Science and Technology put out this big report to the president. Within that report, it calls for the Secretary of HHS to require HIQ to redesign HCAHPS to include questions on patient safety and discrimination. So I'm thinking there's some intersections here that you're bringing up that I would, we'll continue this conversation, but I'm just seeing all these pieces together. And, I just returned from a Leapfrog board meeting, and they were talking about, they do safety grades and each hospitals get grades on safety. And right now they use pretty much administrative data, a lot of CMS data. I'm like, what if we could eventually get to all these patient reported measures, on diagnoses and safety and discrimination, and have hospitals graded on those measures as well? So I'm just saying you're kind of opening Pandora's box for my thinking about what you do with all this, and it's exciting. So great work.
Thanks so much, Sue. You probably recognize some of your contributions to that patient-centered framework. I completely agree. And it's the reason why Eric and I really wanted to plant that seed of thinking about patient-reported measures throughout our conversation. I think the words can be debated, but, something along the lines of just asking, even at the end of a visit, if it's not, in a survey fashion, did you feel heard today? Did I miss something? Just to sort of really help patients feel understood, especially for, patients with LEP or, who may not otherwise feel heard, is so important. And some of the issues around, whether any personal characteristics have, changed the way that patients have been treated during the diagnostic process with regard to the discrimination or disrespect issues. So we look forward to having those conversations. Yep.
Yeah. Thank you.
Lisa.
Yeah, thank you. So I'm listening to everything you said, and I love what you're working on and doing and the direction you're going in. The one thing that I've seen, and I'm just wondering if you're addressing it or considering it, is I think patients really truly need to be educated on how to be patients. The organization I'm with does that, and we find such a difference, even though they don't necessarily remember that much of the detail and specifics. They are empowered, and they feel that they have a right to talk. Patients are, 15 years ago, 10 years ago, probably even, doctors were held up high on a pedestal, and patients didn't feel comfortable talking. So right now, we still don't have full buy-in from the provider community. And how can we make the patients, how can we give them a few skills and confidence? Because I think with that, there would be a leap instead of just maybe a few small steps. But I do love what you're doing, and thank you for doing it.
Thanks, Lisa. I can comment briefly. Eric may have more to say. I'd love to learn more about your organization. If you peek on opennotes.org, there is a section that is specifically targeted and designed for patients, with FAQs, how to read your note, how to prepare for visits. And we would love any input or suggestions on how to make that material stronger or speak more effectively to patients, and would value your input from the knowledge of the work that you do. I think one of the main goals of this new project that we're doing that Eric mentioned regarding development of tools is to actually also create tools specifically for patients that would help them to engage in the diagnostic process. And those would be based off of the behaviors that we find, those teaming behaviors that help diagnostic processes stay on track. So they would use that knowledge to then guide patients to help support those behaviors in the diagnostic process. So that's down the line, but certainly part of our plans.
I'm glad to hear that. If I can just jump back to that. So I have a very extensive background with medical complications and error and harm and communication problems and the whole thing. And I will say that one of the biggest problems that my husband and I experienced were that during the physicians and providers doing all their diagnoses, they never discussed things with us during that process where we would have told them, well, I don't see the results of this particular test that he had done. And it had gotten lost in the shuffle. And we would have certainly asked about it if they hadn't been considering it. And it turned out to be critical to the misdiagnosis. So, you know, that engagement of patients at all points.
Yeah, I think this is really a very, very important point, and it is, you know, it needs to be addressed. I think there's two things that I hear you saying. One is patients need to be just educated. I mean, there's some facts that need to be conveyed to patients about what they can do, what to look for, and what to say. But then, as you just illustrated, they also have to be given the permission, not just permission, but they have to be encouraged to say things and given venues and ways to speak up. So there's tools that we can develop. And then importantly, for every team, there has to be a sense of psychological safety, right? You have to feel like if I do say something, that I'm not going to be, that it's emotionally safe for me to say what I want to say. And, you know, there is decades of research on teens about how we can create psychological safety. And but in healthcare, most physicians and nurses don't think of patients as team members. I mean, They think of patients as something, we're doing something to them. But no, I mean, so it's a big shift, and it's going to take a while. But once patients are thought of as a part of the team, people then can realize that to work effectively, we've got to have psychological safety. Everybody needs to feel comfortable speaking up, and there are ways to do that. It's just gonna take a while.
So I know we're at the top of the hour. Kai had her hand up. Kai, Eric, and Sigal, do you have just a minute to respond to Kai's question?
I can stay.
Okay, go ahead, Kai. I realize if
Thank
others
you
have
so
to
much.
leave, I want to be
Yeah,
respectful.
it's so much. I'm just so excited with everything was presented because that happened to be really my passion. And I'm actually really helping what Lisa just brought up. You know, I really try to empower, you know, each patient based on their situation and creating something tangible. So I definitely, you know, appreciate what you're doing. It's so needed. My just quick question is, I'm just a little bit concerned about the, you know, the general trend about the, you know, visit, you know, through being shorter and shorter, right? And they have too many patients to see, although they may have a great intention, it just may not be feasible, you know, based on the capitalistic reality of our society. So,
Yeah, no, the short visit is an issue, and I think, you know, that's why we need to think about this as a process, right? It's a diagnostic process. So the visit might be the beginning, or it's points along the way, but we have to be able to have open communication over time in between visits, right? And there are definitely ways to do that, and we're hoping to develop some tools to make that easier. And, you know, maybe these chatbots and AI are going to have some potential of downloading some of the work that clinicians have to do right now, whether it's, you know, scribing notes, you know, transcribing stuff, or writing notes, or whatever. But we need to find ways to free time up for clinicians to be able to pay more attention to patients. You know.
I would also add that, you know, one of the beauties of RDX is that it takes some of the work that's happening in the visit and brings it outside of the visit in terms of collecting some of the information about recent history, et cetera. And it's very early data with just a small pilot of clinician participants, so we can't put too much weight in it. But we did ask clinicians how it affected time. And the interesting part to me is, you know, with 100% agreement with your comment that visits are too short. So it's not like we're going to see, you know, clinicians say that, oh yeah, the visit was shorter, you know, with cardiac. But what we did ask about was, did it change the quality of the time that you could spend with patients? Because some of the other stuff, it's almost like Khan, you know, the flipped classroom model, where, you know, if you do kind of the more didactic or rote stuff outside of the classroom, you can spend time face to face really tackling the more challenging stuff in the classroom. And so same idea with this clinic visit, that it gave clinicians more time to spend meaningful time talking with patients and families, so the perception of the visit may be more satisfying. Those are early data, but I hope maybe that will bear out as we continue to do this work.
Thank you so much. I just want to say, Shigal, that's such a excellent point. That must be the only way for our healthcare system work. You know, we have to raise the standard of the, you know, conversation. Yeah. Thank you so much.
You know, I think it's worth underscoring, especially as Eric mentioned, now with technology front and center and the new developments that will certainly come our way with AI, that we must remember that the development of technology is in service to the patient-doctor relationship and not any kind of substitute. So really using it as a way to create more face-to-face time and important relational interactions is key. Thank you.
Sigal and Eric, thank you so much for your time. I mean, there were wonderful comments in the chat. People are very grateful. So we can't thank you enough. We will have this recording. We'll send it out. And I hope you all have a wonderful Thursday. Thank you.
We'll be in touch.
Bye-bye. Appreciate it.
Hey, Carol, do you want to stay on just for a second?
Hold on, wait, I want to make sure.